I think that the pivotal person for the management of patients with plasminogen deficiency is their hematologist. I think it's very important to be tied to a hematology practice that specializes in what we call benign hematology, which are non-malignant diseases. Many of these physicians work with bleeding disorders such as hemophilia and other clotting disorders. So they're very attuned to the need for replacement therapy, how to manage it, the pharmacokinetics, and monitoring of a patient. Uh, It's important to see a hematologist because plasminogen deficiency is a systemic disorder. It affects many different systems in the body, and hematologists who manage hemophilia understand that from the musculoskeletal and other complications that patients with hemophilia have. So plasminogen deficiency is different in how the disorder manifests itself in these different systems. But again, I think the hematologists who run these types of centers and work with patients with clotting factor disorders are very good at finding out any system that might be affected early as possible, because that's when you want to identify that system as being affected and initiate treatment if needed to prevent long-term consequences of the disorder. Hematologists who work at hemophilia treatment centers who work with clotting factor deficiencies are also very good at coordinating care with other subspecialists. So, for example, with hemophilia, we do it very commonly with orthopedics and physical therapy, but also with many other subspecialists for whatever the patient needs. And the same is true for plasminogen deficiency. We can coordinate care with ophthalmology, ear, nose, and throat, pulmonary, renal, whatever system is involved. We can assure that the patient undergoes that evaluation or intervention in the safest possible manner. So adjusting an individual's infusion therapy can be done depending on whether they are on intermittent therapy or continuous therapy. If you're on continuous therapy for suppression of symptoms, you can time your therapy to give you the best level prior to a procedure, for example, and you can work with your hematologist to determine if your schedule needs to be somewhat intensified after a procedure or an intervention to assure the best outcome and appropriate healing from that intervention. During times of acute illness, it may be advisable to uh, alter your infusion schedule, even if you're on continuous infusion. So, for example, if you're on continuous suppressive therapy, but you spread out the interval and found that that longer interval still suppresses symptoms, during an acute infection or event, you may need to shorten that interval back to the standard interval to make sure that that episode doesn't precipitate forming new lesions. If you're on intermittent therapy, meaning you're only using therapy for specific symptoms when they develop, if you have an intervention planned or an acute illness, you would want to speak to your hematologist about potentially starting therapy during that time to get you through the acute event or infection. So, for example, this can be thought of with hemophilia. When you have severe disease with hemophilia, you're on what we call continuous prophylaxis to modify your level of disease so that you prevent bleeding episodes. So rather than treat them when they occur, the best form of therapy is prevention, and that would be the same type of therapy as continuous therapy for plasminogen deficiency. There are some individuals with hemophilia that have more mild disease and only treat when they're undergoing an intervention or have a particular bleeding episode. And the same could be true for plasminogen deficiency. There may be some individuals who only develop symptoms occasionally and may require treatment during that time, or if they have an acute infection, might require treatment during that time to prevent lesions from occurring. Women and girls who have plasminogen deficiency can develop symptoms in the genital tract. What's interesting about this disorder is we have seen children develop lesions in the genital tract as well, even pre-menarche. It can be a manifestation of the disease based upon that person's specific expression of the disorder, or it could be a manifestation that develops because of an infection or injury or irritation in the area. We would recommend treating and just making sure that the parents of children who are pre-menarche and the physicians, the hematologists, the pediatric hematologists who care for them, ask questions about this, or that the family notify the hematologist if any symptoms develop. Those symptoms can be seen visually sometimes if they are on the external genitalia. If they're internal, the child may complain of passing lesions that you can actually see or discomfort in the area. Once menarche begins, symptoms can develop around that time or afterwards. You can develop what we call dysmenorrhea or pain with menses. That can occur in individuals even without plasminogen deficiency. But if you think your child is having significant issues, it would be a good thing to bring up and potentially evaluate, because lesions can occur deep in the vaginal vault or on the cervix or even in the endometrium, the lining of the uterus itself. They may have difficulty with their menses in terms of normal passage of menstrual fluid. It may be difficult. It may have associated membranes with the blood. So looking at what's passed may sometimes be helpful as well. Women later in life may have symptoms in the genitourinary tract, including pain with intercourse, bleeding with intercourse, difficulties becoming pregnant, and those can be manifestations of plasminogen deficiency as well. Before adequate replacement therapy was available, there were some reports in the literature that the use of hormonal therapy actually increased your plasminogen levels and was helpful in treating some of the symptoms of the disease. From my personal experience, I can say that the hormonal medications that I've utilized in patients have not improved symptoms outside of the genitourinary tract, but have been helpful in helping modulate the menses and control the menses. But if you have real lesions within the uterus or the cervix, I think that really requires replacement therapy as well to heal those lesions and resolve them, because hormonal therapy may help with the heaviness of the menstrual flow, but it won't necessarily heal those lesions. So plasminogen deficiency is not a disorder that is necessarily, the symptoms are necessarily precipitated by excess activity. So that's quite different than hemophilia, where hemophilia clearly you can become injured and precipitate bleeding. That's not true with plasminogen deficiency. What we do become concerned about with plasminogen deficiency are injuries to areas that have mucous membranes where lesions can develop. Most commonly, that is the eyes and the mouth. So, for example, if you're participating in swimming, we might recommend that you wear goggles to protect your eyes so that they don't become irritated and inflamed during that activity. The same could be true, for example, with soccer, where there might be a lot of dust on a field, or, for example, other activities that where you're running around and it's a dusty field and there's irritants that can affect your eyes. That would be something we would say wear goggles for. All of that being said, if you're participating in a sporting activity and you do have an injury that's significant, people with plasminogen deficiency do have difficulty with wound healing. And we would recommend that in addition to, for example, if you have a broken bone, you might want to start replacement therapy or change your infusion interval to promote the best wound healing that can occur.
Okay.
Plasminogen deficiency is typically thought of as a disorder that affects areas that have mucous membranes. Most people think of these areas as the eyes, the mouth, the gastrointestinal tract, but there are many other areas of the body that have the same type of membrane lining that plasminogen can affect as well. So, for example, the kidney, the urinary tract, the ureters, the bladder can be affected. The respiratory tract, the vocal cords, your tonsils, your gums, your inner ear, all of those areas can be affected. There are some individuals that have central nervous system problems that are related to plasminogen deficiency. It's called obstructive hydrocephalus, and they can develop something called a Dandy-Walker cyst. That has to do with the ability of the cerebral spinal fluid to drain appropriately. And if you form fibrin lesions, fibrinous lesions in that area, it obstructs the flow of the cerebral spinal fluid and can obstruct the normal drainage of that and cause pressure on the brain. That is not the most frequent symptom of this disorder, but it is clearly seen. And people need to be aware of that. That is a manifestation of the disease. So even though we think or typically talk about mucous membranes, there are many areas of the body where the disease can manifest itself. As physicians, what we really would like to have for plasminogen deficiencies is an ability to help guide the conversation and predict a patient's course with this disorder. That is done through the development of what we call severity categories. So we can use certain markers, for example, the level, the genetics, different things that can be associated with the disorder to help us develop severity categories. But unfortunately, we have not been able to do that as yet very clearly with plasminogen deficiency. As part of our work to understand that and develop these categories, we are conducting an international natural history study, and we are banking samples to try to unravel those factors that impact expression of disease. It clearly may be more than the actual genetic alteration in the gene that codes for plasminogen. We know at this point in time that just the genetics and just the level are not necessarily predictive of an individual's course. So we are looking at other coagulation factors that are important in the area of coagulation that plasminogen works, which is called fibrinolysis. We are going to potentially look at um, perhaps inflammatory genes that may be inherited completely separately, but may impact expression of disease. So there's a lot to learn about plasminogen deficiency. We're in the early stages because this deficiency is so rare. It is hard to get enough people worldwide to participate in studies like this to really unravel and understand how we can increase knowledge and help families and patients predict their course and tailor their therapy to their needs. What's very interesting about type 1 plasminogen deficiency or hypoplasminogenemia is that people, even with very low levels of plasminogen activity, do not develop what we call spontaneous uh, venous thrombosis or embolic events. You would think because of plasminogen's role in dissolving clots once they form, that venous thrombosis would be a manifestation of this disorder. It is not. And I think that's quite interesting and points to plasminogen's other very important roles in bodily functions, which is maintaining the extravascular matrix and keeping it clean and healed in people's bodies. If you do have the placement of a foreign body, so for example, if you have a central venous access device, sometimes called a port or a PICC line if it's temporary, those devices can precipitate the formation of fibrin sheaths and clots in an individual with plasminogen deficiency. So whereas they will not develop one spontaneously, they can, with a trigger such as a device, develop clotting or fibrin sheaths around those devices. And so you have to be careful when you place those devices. You should be on replacement therapy to prevent that from happening. That can also occur with shunts that are utilized for people with hydrocephalus for occlusion of the cerebral spinal fluid. Those individuals often require continuous replacement therapy to make sure that the device does not become occluded and blocked. There is ongoing research for individuals with plasminogen deficiency. As I mentioned before, there is an international natural history study. It's called HISTORY, HISTORY. It is listed on clinicaltrials.gov. It is occurring now in many countries around the world. We've enrolled patients from the Middle East, from all over Europe, from South America, the United States, Canada, many other countries, to try to collect enough information and samples to help us understand the course of this disorder and to help unravel what we want to really know to advance care, which are the development of severity categories and those things that contribute to the development of symptoms in individuals. As you know, plasminogen deficiency is very variable disorder in some people. Some people have continuous symptoms from a very young age. Other individuals develop symptoms only intermittently, and those symptoms can wax and wane, disappear for years, come back years later. We've heard of individuals developing what we call ligneous conjunctivitis or eye lesions as late as in their late 50s, early 60s for the first time. So we really don't understand why some people are symptomatic from a very young age, continuously symptomatic, or intermittently symptomatic. And we need to understand that to tailor our treatment for each individual so that we don't overtreat some people or undertreat other individuals.